Hello, my name is Sylvia Nelsen, and I'm presenting on behalf of Team Skillit on the topic of hard tissue diagnostic instruments used in predoctoral clinics. More specifically, we were interested in understanding which instruments students are taught to employ for diagnosis of various hard tissue defects, and how they relate to best practices as reported in the literature, with the ultimate goal of integrating our understanding into the broader context of competency-based education. I'd like to begin from the zoomed-out perspective of this broader context by defining competency-based education, or CBE. In her written testimony to the U.S. House of Representatives, the executive director of the Competency-Based Education Network defined CBE as an approach to curricular design in which students acquire and demonstrate their knowledge and skills by engaging in learning exercises, activities, and experiences that align with clearly defined programmatic outcomes. As with other educational models, an essential aspect of CBE is strong alignment between what students should learn, how they learn it, and how they demonstrate that they have learned it. In the context of dentistry, that means first defining what knowledge, skills, and attitudes a dental practitioner should be competent in, then designing learning experiences that effectively teach those attributes, and finally providing both formative and summative feedback to students so that both educators and learners know when those attributes have been attained. In CBE, learning and assessment are time variable, and assessments are specifically designed to allow students to demonstrate their competence. Our goal was to explore how hard tissue diagnosis in particular currently fits into this educational model, and to define recommendations for how educators might improve current practices to better align with the competency-based model. Why did we choose to focus on hard tissue diagnosis? Hard tissue defects are common issues that all students will encounter in their dental practice. More than 90% of adults in the United States experience some type of pathology of hard tissue. Given their prevalence, numerous strategies have been developed for diagnosis, from basic physical exams utilizing an explorer to cutting-edge technologies, and more are constantly being developed. It can be difficult to know which approaches are the most effective, especially since comprehensive information about the available tools is scarce. The relevant competencies that have been defined by IDEA are relatively high level, meaning that they are not intended to dictate which specific diagnostic tools are taught for any given application. This lack of clarity at a more detailed level led us to endeavor to understand what is currently taught in predoctoral programs and what evidence in the literature suggests should be taught. To address these questions, we created a survey asking which diagnostic tools are currently taught for 6 different hard tissue applications, and we reviewed the literature to summarize the evidence-based sensitivity, specificity, and reproducibility of the diagnostic tools typically employed or being developed for each application. The survey was sent via the IDEA mailing list to academic deans from 62 undergraduate dental programs in the United States for a national cross-sectional analysis. 27 deans from across the country, or their designated representative, responded for a 44% response rate. The number of matriculating students in these programs ranged from 35 to 240 students, with a mean of 93 and a median of 85. For each of the 6 hard tissue diagnosis applications, respondents were asked which diagnostic tools their predoctoral students are taught to use. Beginning with caries detection, the survey results indicate that close to 100% of schools teach students to utilize an explorer and radiography as the primary diagnostic methods. Similarly, transillumination is taught in the core curriculum of over 90% of schools. Caries detector dyes are also part of the core curriculum in over half of the schools, though some comments indicate that the high frequency of false positives is specifically emphasized in their teaching. Other methods, such as caries detector cameras, like SopraLife, and those involving near-infrared light transillumination, like Diagnostic, are also taught, but in fewer than 50% of schools, even when core and elective curricula are combined. These data are in agreement with the published gold standard for caries detection, which consists of visual screening using white light, tactile screening with an explorer, and radiography to provide supplemental information regarding inaccessible surfaces and depth of existing decay. The advantages of visuotactile screening with radiography are that this method detects approximately 80% of lesions, and they are relatively inexpensive to perform. However, they do involve exposing patients to radiation, and probing root surfaces may create defects. Also, diagnostic accuracy is limited in regions that are difficult to view. Caries detector dye and near-infrared laser fluorescence can detect additional lesions, but it's not clear if these are real defects or false positives. This is of significant concern because studies have shown that many minor lesions fail to progress over time, while unnecessarily restoring a tooth initiates a cycle of re-restoration that can significantly weaken the tooth. Caries detector cameras offer increased ease of diagnosis, and optical coherence tomography may increase the ability to detect subsurface lesions, but both currently have limited practicability due to cost. For evaluation of tooth vitality, the survey results indicate that 100% of schools teach students to utilize compressed refrigerant spray to perform a cold pulp test, and use of an electronic pulp vitality tester is taught to at least some students in all but one school. The one school that reported not teaching EPT at all indicated that percussion and palpation were taught in addition to CPT. These, along with periodontal probing, were the most common supplemental diagnostic methods listed by respondents. In addition, 70% of schools teach at least some of their students to perform a heat pulp test. Literature supports use of CPT and EPT together as a primary method of pulp testing due to diagnostic accuracy. CPT in particular correctly identifies non-vital pulp, while EPT is likely to correctly identify vital teeth, and both methods are easy to employ. EPT, on the other hand, is less likely to correctly identify necrotic teeth, and operator error in either test can contribute to an incorrect assessment of pulp vitality. Though several schools reported teaching percussion as a method for identifying non-vital pulp, this was found to have low validity. And in spite of the frequency of heat pulp testing in dental curricula, it was found to be the least accurate pulp testing method. For evaluation of occlusal contacts between maxillary and mandibular teeth, 100% of the responding schools are currently using articulating paper and mounted diagnostic casts as the main tools. In fact, 56% of the respondents reported that they do not teach students to use any other diagnostic tool for this application. 11% of schools teach the use of T-scan technology in their core curricula, and an additional 19% teach this technology in optional or elective curricula. Approximately the same number of schools teach students to superimpose a series of scans, though more often in elective rather than core curricula. Other methods listed were the use of shim-stock, digital diagnostic mountings, radiographic images, and occlusal wear patterns. These data are in agreement with the literature, which cites articulating paper as one of the most commonly used diagnostic tools to identify occlusal contacts due to its low expense and ease of use. However, interpretation of the marks on articulating paper can be subjective and inaccurate, and some research has shown that shim-stock may be more accurate and reliable. Mounted diagnostic casts are also commonly used. They provide a 3D view of both maxillary and mandibular dentition occluding together, but they do require additional steps to obtain the impression and occlusal record to mount models. T-scan is a technology that was developed more recently. It is especially useful because it provides a mean to subjectively evaluate occlusal and articulating relations and therefore minimizes operator bias. The technology is still evolving though, and while the newer models seem to be very accurate, they are still relatively cumbersome and expensive to use. When asked which diagnostic tools students are taught for implant therapy, 26 of 27 respondents reported using a combination of cone beam CT and 2D radiography to evaluate bone volume for implant planning, and one school uses only CBCT. In addition, when core and elective curricula are taken together, 56% of schools teach the use of diagnostic casts for implant placement planning. Other techniques listed were photographs and patient radiographic history, but only one school indicated that they utilized treatment planning software. Once an implant is placed, it is important to assess osseointegration, since successful osseointegration is a prerequisite for functional dental implants. Combining both core and elective curricula, this is accomplished via mechanical means, such as probing or torque testing, and radiography in 37% of schools. About half of these additionally teach resonance frequency analysis using an Austel device, and 19% of schools teach Austel only. Surprisingly, 44% of respondents indicated that they do not teach Austel or any other test of osseointegration. So it is not clear how students are taught to evaluate the success of their implant therapy. Implant therapy is a relatively new application in predoctoral dental training. Both European and U.S. academic dental institutions recognized an increase in patient demand and recommended inclusion of implant therapy at the predoctoral level to address this demand. Accordingly, only 33% of U.S. dental schools reported including implant therapy in their curricula in 1974, but this increased to 84% by 2002, and our data suggests that all schools now teach it. Current recommendations advise schools not only to include implant therapy in their curricula, but to specifically incorporate the use of 3D virtual planning, which uses data from CBCT to create 3D images of the jaw, and surgical guide software instead of more traditional techniques to better inform the dentist regarding optimal implant placement and the necessity of a bone graft. Modern dentistry utilizes a variety of tools for aesthetic evaluation. Review of the literature revealed that these tools are divided into two different areas, with some literature focusing on shade matching with restorative materials, and the rest of the literature focusing on the aesthetic evaluation with regard to treatment planning. In both cases, the majority of the diagnostic tools involve digital imaging of some sort. Consistent with this, our results reveal that 23 of 27 survey respondents teach all students to utilize digital photography for aesthetic evaluation as part of the core curricula, and 3 schools responded that it is taught in optional or elective curricula. However, it is worth noting that while the responses did indicate digital photography is widely used, our survey didn't ask for elaboration regarding how it is used. For example, are students using theories such as the golden proportion to evaluate how pleasing the aesthetics are or to improve them? Are they using it for smile design to help patients and providers make decisions regarding treatment aesthetics? The use of digital technology has many applications, and how it is being utilized can vary greatly from institution to institution. When asked to specify other diagnostic tools employed for aesthetic evaluation, Diagnostic Wax-Up was listed by 4 respondents, with others mentioning digital mock-ups and CAD/CAM software, smile design, visual evaluation, shade guides, and patient historical records comparisons. And finally, our survey asked which diagnostic tools are predoctoral students taught to employ for evaluation of other bone anomalies, such as bone loss, periapical lesions, etc. Responses indicate that 100% of the schools use radiography for this application. In addition, 7 survey participants stated that they also teach students to utilize CBCT when additional information is needed. Other tools or methods listed were a pathology worksheet, periodontal probe, and periodontal records for comparison of patients' bone loss patterns. The survey specifically mentioned bone loss and periapical lesions, but radiographic imaging is used to identify other common lesions as well, including tori and exostoses. Reports vary widely, but the prevalence of tori may be as high as 66%, and they can affect speech, function, and fabrication of removable prostheses, so their characterization can be important. Based on survey responses from academic deans from approximately 44% of U.S. predoctoral dental programs across the country and review of the literature, we conclude that most diagnostic tools being taught align with the best practices according to evidence-based sensitivity, specificity, and reproducibility. However, new technologies may supplement or replace traditional methods as evidence of their effectiveness improves and their use becomes more feasible. More specifically, caries detector cameras and optical coherence tomography may improve the sensitivity of caries detection while maintaining specificity and reproducibility if practicability can be improved. Cold pulp test combined with electronic pulp test are excellent for evaluation of tooth vitality, but heat pulp test and percussion are less accurate. T-scan may provide a more subjective evaluation of occlusal and articulating relations than articulating paper, especially as more accurate scanners are developed and ease of use is improved. Implant therapy, especially employing 3D virtual planning and surgical guide software, should be included in predoctoral curricula. Use of digital technology for evaluation of aesthetics has many applications, and how it is being utilized can vary greatly. Perhaps there should be discussion about standardizing what techniques are taught for specific applications. And finally, imaging, standard radiography, and cone beam CT remain the primary methods for diagnosis of other hard tissue anomalies. This preliminary study focused on the question of what hard tissue diagnostic tools predoctoral students are currently taught and what evidence-based practices suggest should be taught. We hope to expand this research and close the loop by asking how these diagnostic tools are taught, how mastery of each is assessed, and how this can be accomplished in a time-variable manner. The references we used for this presentation are listed here. Team Skillit would like to thank the IDEA and Emerging Leaders Program for this opportunity, all of the educators who took the time to respond to our survey, and Dr. Robert Spears for his support and guidance. Thank you all for listening. We look forward to your questions and feedback.